There were other works that were published before, so they were also excluded. So from the exclusion and inclusion criteria, 147 were removed. We pre-selected 86 studies and manual search 37. Some studies could not be recovered, and the author did not reply or not answer to the demand. These were 4 studies. There were 119 tracked studies, and we had another deep evaluation or assessment or inclusion and exclusion factors, 68. And in order to compose the map, we chose 51 articles that were actually considered based on this very rigid selection, a very rigorous selection. So this is the distribution in reference to the database. So you have set 74% of selected reviews. They were extracted from PubMed and Medline. So at the end, and then CNAHL and Bayes and BVS at the end. So it was already expected. It was found on PubMed. So the kinds of reviews, systematic reviews, 61% of the cases were recovered. Only meta-analysis was 8%, and systematic review with meta-analysis 25%, and systematic review exclusively from clinical randomized clinical essays. This was 6%. The other reviews that were not coming exclusively from randomized essays, they came from systematic review beyond the clinical essay. Now, in reference to these pictures here, you see 61% of clinical trials. Now, these are the studies, the conclusion to the studies. These are randomized trials or not, 18%, and 21% clinical trials plus observational trials. So the great majority of the systematic review studies included clinical trials that were randomized. And here there's an interesting thing, that is the quality of periodicals. So we rescued or we extracted each one of the 51 periodicals that compose the final selection. And we went after quality. We ranked these periodicals. We used the SJR classification that separates the periodicals in quarters depending on their position in the ranking, and also the impact index or impact factor. So the average impact factor was 9.38, which is a good average or medium. And when we look at quarters 1 and 2, which are best positioned in the ranking, that corresponded to 47% the first quarter and 29% the second quarter. So these are reviews that are published in high quality magazines. Those that are more simple in the quarter number 4, they corresponded to about 8% of reviews, and the ones that don't have any ranking or no classification is 6%. So the greatest volume came from high quality magazines, and this is the world distribution where publications came from, or in which countries these periodicals are published. So the great majority came from the United Kingdom, because these are systematic reviews, and the United Kingdom is where we see this type of approach as being more traditional. So it's the country's leader in this kind of study, followed by United States and Germany, Brazil 2, South Africa 3, and India, and so on. So the great percentage of the systematic reviews comes from the United Kingdom, and in this study was not different. So we focus on countries in the primary studies. We were able to map and find out where we can do clinical trials in homeopathy that will result in the outcomes that we achieved. So we see 12 in United Kingdom, 8 United States, 7 from France, 6 Norway, 6 from India, which is a strong country, 8 from Brazil, and the distribution was spread all over the world. Even from Australia, we got some data, and this way we were able to get a global view. So it's good that the samples represent a specific country and specific regions. Now, when it comes to the intervention categories, we classify them in order to make it easier to understand. So we separated the medicines that had our commercial formulas and the compounding homeopathy, that we call it classical homeopathy. We may have to change this name here because Rachel said that in the United Kingdom, classic homeopathy, it has to do with individualized treatment. So that might generate some confusion. So we might change it here. But these are compounded medications and commercial formulas. There are, and here commercial formulas that are linked to bigger labs. But the great majority came from the classical homeopathy. And here we have a division within the homeopathy and the compounding medications. We compared here the approach of each one of the studies. So clinical homeopathy is the one that treats a specific disease. For example, if you have some kind of contusion, you use arnica. And we also, and then we have like individualized treatment, use of complex esotherapics, and there were non-specified strategies. That's when they said homeopathy without specifying what approach they use or what method. And there's the semi-individualized treatment that was very interesting. The author of the study has a list of medications, but he will only add patients that. So some of the studies had this kind of tools used, and then so we kind of put individualized treatment and clinical homeopathy as composing the majority of the results of the study. So here we have a very homogeneous division among the different groups. We have a very homogeneous distribution of the different diseases and problems. For example, chronic diseases, infecto-contagious diseases, metabolic diseases, pain, mental health, reproductive health, oral health, well-being, quality of life, and other issues that we gathered here in another separate group. Otherwise, you would have a pizza with very small slices. So here we say well-being and quality of life, only 7%. And that's very interesting. It may be that we need to pay attention in the future to this part here, because homeopathy has a greater possibility to show its effects, because depending on the patient, the well-being is the first one who starts improving. So I think we need to focus more on this part of the study. So the results, the positive results were the ones that had a significant statistic correlation to control. And the primary study followed a methodological quality that was perfect, very well ranked. And there's a matrix to apply to this as well. Now, potentially positive. In that sense, the author pointed out that there was a statistical significance in relation to control, but there was some kind of bias. And so there was the risk of a bias here and there. We don't know if that will affect the results. So there was some kind of concerns, and usually the author of the review would say, it's a little bit, it's not completely conclusive. Well, but there's a statistical significance. So that means there's a potential, but there needs to be more studies that take into account the risk of bias. So then that we can have to decide if these results will come to the potentially positive role or no effect. So there's a potential here, but we need to study more. So it was important to make this separation, because if we base ourselves only on the debate from each reviewer, we will not get anywhere, because there was a number of articles. There were very different potencies, very different medications. So it's very varied. And the methodology also changed from article to article. So this classification, or this hierarchy here will help us try to map our results. And the results sometimes are so, and here we see inconclusive. It's when the data is contradictory or methodology is controversial. And the negative results, these are the studies that only reported adverse effects and nothing else. And what we noticed here is when we add all the studied intervention, all the categories of homeopathic strategies, we saw that in negative result, no article, 0. It doesn't even show here in the graph. Inconclusive, 11%. Positive, 16%. Potentially positive, 33%. And no effects, 40%. So here we have nearly half of the systematic reviews bringing results that were either positive or potentially positive. So we can see that it's important to refine methodology, so we can dismember this potentially positive result and see how many will fall into the blue group as the methodology gets refined within the next years. And we think the contribution of SCAPA will be this one. And now separating by strategy, we have clinical homeopathy, individualized treatment, and complexes. They had more or less the same distribution in terms of percentage of positive results and potentially positive results and no effects. Now the isotherapics were a little bit different. We had a great quantity of potentially positive results, and 22% of no effects. So that shows that we need to take a look of what's happening in isotherapy so that we can refine a little bit more the methodology. But still, we have a great deal of results if we add positive to potentially positive, positive with potentially positive, blue and yellow. We have a great deal of results. And we see that the blue one is promising, but we need to improve the methodology. So these are the same results viewed from a different perspective of results and intervention. The next chart is a little bit more summarized. I decided to call it possible evidences. So these are the possible evidences. These are positive and potentially positive results compared to with no effect. So we see a predominance in different approaches, especially in individual treatment, the difference was greater, and esotherapics, the difference was greater, and non-specified and semi-individualized treatment, there was an inversion here. But I wouldn't get very surprised because this was very small here. So non-specified tends to disappear because it's not acceptable to have some kind of work where we don't specify the homeopathic treatment used. And semi-individualized treatment, it's interesting. So if we can maintain the increased N, I would look at this with a bit of reservation, but I will analyze it a little bit further. And here we see that there's a possible evidence, but we need to improve our methodology. And this is very interesting too. This was a suggestion from coordinator Mariana. Let's see that this result, let's see, these reviews, these results are different from depending on the type of systematic review. Depending on the type of review, we have positive results, potentially positive results, or inconclusive. The type of results were about the same. So there was a bias. The systematic review without meta-analysis had lots of positive reviews. Well, we didn't see this. So this distribution is equal to all review models. So all this type of bias, or the bias that has to do to the type of review, this did not occur in this example. And the trust degree of trust. So the AMSTAR 2 that analyzes the quality of systematic review, the team that analyzed that through AMSTAR classified the degree of trust in low, high, and critically low. And it has to do with the specific aspects of systematic review. So the high degree of trust had this distribution of positive, potentially positive, no effects and inconclusive. They were kind of similar and equal. And the low degree of trust, we see the potentially positive and no effects bigger. And so we don't see that the weakest reviews produce negative results or the stronger reviews produce positive results. No, this did not occur. So there is no bias in the quality of review. Now let's look at the evidences. Here I put a picture of Chitãozinho e Chororó. So for those who are not watching, they're not Brazilian. I think I must explain. In Brazil, there's a country type of music we call música sertaneja, which is country music in Brazil, and they sing those songs in a duo. And these are one of the most famous duos. And this is the name of a song that was sang, that is sang by them. And one of the famous ones and evidences. So when we talk about evidences, I remember this song by the Chitãozinho e Chororó.
So here we have a group of 7 systematic review articles that were graded the top score from AMSTA. So we have top-notch reviews based on all the Cochrane's criteria. That was reflected in MSTAR 2 analysis. So this is a cherry on top. Actually, this is the stem of the cherry on top. So we are talking about the highest aspect of those pieces of evidence. What did it show? This is a picture, a snapshot of the map. This is what kind of information we collected from the top 7 reviews. In a graph, we have green and white dots. And we have, so the green dots are positive and the white ones are potentially positive. The color choice is just random, right? That's why we chose those colors. The best reviews and the best results, it has nothing to do with soccer, and one of the teams we have in Brazil has been a champion recently, but that's just out of coincidence. So the green dots and the white dots are, so the green are positive, the white dots are potentially positive. From the positive, we have some outcomes. For example, fibromyalgia, we had individualized treatment, medium otitis, also diarrhea, and ADHD in children, also potentially positive. And other diseases, other disorders, for example, the flu, there was potentially positive, periodontitis, positive, potentially positive, other gastrointestinal disorders too, and mental health. We're talking about the HT2. And the compounded medication, we had the homeopathic remedies had a positive for post menopause. What does that mean? What does it mean? Is homeopathy for those diseases? No. We just picked articles that are based on what we have nowadays. So that's the result we have. It shows a sign, a small sign that we have robust evidence about how effective homeopathy clinically is. Today we have about these diseases here on the screen. As time goes by and we have more research happening, more reviews, the more, or actually the better quality of these reviews are as time goes by. In the future, we are going to have a greater number of disorders. This is just a very tiny little seed for the future, so we can have a greater chart with robust evidence coming from future studies. Conclusions. Yes, there is evidence about how homeopathy is effective to several conditions. 76% of the publications were published in important journals and other publications. The results were equally distributed among types of reviews and AMSTAR 2 scores. There was no biases in terms of what kind of review and what kind of publication and the results they provided. Remember the kind of publications you're talking about. They were quality publications. And when you see the distribution among the types of publications, you don't see differences. between the results and the type of journal and publication. So the best and not so good, they are the same. I mean, they are all good because they're indexed, but we are talking about making a difference between those who are on the top ranking and those are the lower ranking, and they have this a similar uh, results. So there is no biases in that regard. There is a great diversity of studies and a small number of studies for each condition. We have a broad range, a myriad of things. So all the studies, they are sprayed out, sprinkled in different studies, using different potencies, different medications and remedies for different diseases. Treatment has used one method by one author and a different one by another author. So this myriad of very uh, different results, it makes it difficult for us to have a more concise result. There is a great heterogeneity of protocols. How can we improve the accuracy and relevance of future studies? It is important to bear in mind that even Oberton added this item while talking about the work. We should not confuse standardization of homeopathic approach for a clinical trial for a scientific student. Do not confuse it with the clinical trial approach on the daily basis. The fact that you have to standardize your clinical approach for a study doesn't mean you have to follow that table strictly during the day by day. They prefer to see the patient and try to find the best strategy for each patient. That's what we mean by individualization of treatment, and we cannot lose that. But when you are studying, you're having a study, you have to standardize it. Otherwise, you won't have a reliable result. One thing is your daily practice, and the other thing is our study. This is the first thing to bear in mind. Oftentimes we see some homeopathy doctors, they don't want to have this methodology standardization, thinking that they're going to be stiffened in their practice. No, we are talking about research, not daily, day-to-day practice. How can I improve accuracy and relevance of these studies? First of all, keep in mind the principles of good clinical practice. It helps standardize this and reduce this great range of studies, which creates a bias. Standardization of treatment, it doesn't mean treating everyone with the same thing. It can be, but no, necessarily. You can individualize it as long as you standardize your method of individualization. And that makes it much easier for you to have more consistent results. Creating protocols by multidisciplinary teams. This is key, including homeopaths and non-homeopaths, both with expertise in clinical and epidemiological research. Because more people thinking about it, that's going to be best. If you listen to somebody who is not a homeopath, but then he or she is experienced in epidemiological research, this person can tell you a lot of weaknesses and weak spots of your research, and then talking you can find an ideal aspect. And the same applies to homeopathy clinical trial without only with non-homeopath doctors. It's not going to work because there's a lot of peculiarities of homeopathy that are not going to be considered in this study. Now, if you put both sides together, sitting down and discussing like grown-ups they are, they can have a consistent clinical trial. If we do that, we're going to have plenty of consistent clinical trials, and then that's going to result in reviews that are more consistent, and the results are going to pop up in our screens. It's just like that. It's a matter of organization, pretty much. At least that's the conclusion I got to. That's what my lesson learned throughout this year. And consider the approach or take into consideration the global status of the patient. So that's what homeopathy does it. And then you say, oh, there is no evidence on that. Yeah, that's not something homeopathy is doing. So you're not going to find evidence. So we need to have there is a number of tools to study well-being and quality of life that can be better explored in such researches. While developing a protocol, we should analyze how those conclusions are going to be analyzed. The other day, I was studying a systematic review, which was not added to the map because it was a systematic review about bovine mastitis. And we only analyzed clinical studies using human beings. So that's why I didn't use this review. However, I was reading this about this disease treated with homeopathy, and the author said there is no evidence that homeopathy can treat mastitis because a period. Then I read it. I read the article, and then it said criteria or definition of the outcomes. Microbiological counting, microbiological assessment, number of microorganisms, number of units that created colonies, and metabolic scores for bovines that are also a classic in veterinary. So when you start looking at the way they analyze the outcome, the general status of this patient, all the systems, a bunch of systems were not considered. They worked on an antibiogram analyzing culture of bacteria with homeopathy. It's not going to work because homeopathy is not that. It's not antibiotic. That's not what it does. It does something else. And sometimes the author not knowing a homeopathy does something different that they get to a conclusion that it's not an antibiotic. And they shouldn't have a study for that because it is not, right? But if he had talked to a homeopath, they would have heard that, okay, you are not going to get to a result. This is going to be redundant. MCT, the metabolic study, shows the number of leukocytes in the milk. The untreated animal, if there is a lower number, there is more mastitis. But if it was treated with homeopathy, you may have more leukocytes. It doesn't mean that mastitis improved. No, it means that the animal is responding to the infection. So those parameters in isolation do not analyze the result expected from homeopathy. Why did it happen? It's a design error because they were not homeopath and they didn't invite somebody who understands the area. So we need to change this mindset. We need to start talking to one another, listening to the controversies, and sometimes controversies are not that controversies. They sometimes are complementary. They help you build a model, and we can develop a lot of cool stuff when we stop and talk to each other. Thank you all for your attention. I hope